안녕하십니까. 이게는 koreanemdocs.org의 크리스토퍼 리 이종서입니다. 요즘엔 지금 아직까지 9월달이기 때문에 인턴, 그러니까 레지던트 1년차, 즉 인턴, first year resident를 미국에서는 인턴이라고 하는데, 많은 지금 first year resident들이 이제 클리니컬 에리어에서 일을 시작했고, 많은 질문들이 나오죠. chest pain으로 들어온다. 그러면 제일 기본적인 걸 가르쳐 주죠. chest pain, 흉통, 가슴이 아프다. 일단은 간단하게 five things you need to rule out. First, ACS/MI, acute coronary syndrome/myocardial infarct. 두 번째, acute aortic dissection. 세 번째, acute pulmonary embolism. 네 번째, tension pneumothorax. 다섯 번째, 요즘 endoscopy를 많이 하죠. endoscopy. esophageal rupture, called Boerhaave syndrome. 다섯 가지. everything, every complaint, headache, 5 complaints, 5 causes. 응급병은 간단하게 12가지의 differential, 14가지, 20가지가 아니고 간단하게 5가지, 모든 걸 5가지 응급의학 레지던트 1년차한테 가르쳐 주려고 합니다. acute pulmonary embolism이 많죠. pulmonary embolism, Verkuy's triad, venous stasis. 두 번째, intimal injury. 세 번째, hypercoagulable state. venous stasis, immobilization, prolonged immobilization. 비행기를 오래 탔다. 아니면 버스나 자동차를 오래 타고 운전을 하고 immobilization. magic hour, magic 시간은 6시간입니다. 6시간. 12시간 이상, 6시간 이상 가는 비행기는 6시간마다 한 번씩 걸어줘야 됩니다. 그렇지 않으면 you have venous stasis, you are at risk for DVT and a PE. How do you risk stratify? 어떻게 어떤 환자들을 우리가 low risk, moderate risk, high risk, pretest probability를 어느 정도 알고 그 다음에 further study를 우리가 dictate 하냐 안 하느냐를 많이 물어보죠. 일단 오늘은 acute PE에 대해서 risk stratify를 어떻게 하는지. 옛날에는 우리가 제가 의과대학 다닐 때는 we study with PIOPET 1, pretest probability. Is it low? Is it moderate? Is it high? When you walk into the room, what is your clinical gestalt? 그냥 환자를 봐서 나오자마자 you probably looked at heart rate. Is it tachycardic? Is it tachypneic? Is it low oxygen saturation? Does the patient taking hypercoagulable state medication like oral contraceptive pill or trauma? 어느 정도 우리가 그걸 물어보고 우리가 나왔을 때 그냥 clinical gestalt 보고 와서 이 환자가 low, moderate, high risk로 그냥 clinically 우리가 저지를 했는데 요즘에는 그냥 그렇게 clinical gestalt보다는 we use clinical decision rule for everything. 많은 경우 우리가 이런 clinical decision rule 같은 걸 스터디를 많이 하죠. 왜 그런 스터디를 많이 하냐면 to prevent unnecessary CT, unnecessary MRI, further unnecessary admission. 지금 미국에는 많은 병원에 침대, 베드 숫자는 줄이고 있습니다. 하지만 응급실은 늘리고 있습니다. 그 뜻은 응급실에서 모든 걸 다 처리하고 진단을 내리고 스테이블라이즈하고 집에 보내는 걸 원하고 입원을 하지 않기를 원합니다. 만약에 한다면 they go to like ICU level, intensive care unit. 그러니까 regular floor 같은 경우는 많이 줄이고 있고 거의 MICU, intensive care unit이나 응급실은 느리고 그걸 더 나아가서 이틀 이상 입원을 안 하면, admission 하면 they don't pay. CMS, Centers for Medicaid and Medicare, do not pay. So what we do is we open up observation units. So we admit to hospital observation status. It's not technically admission. 이틀 정도 후에 퇴원할 수 있는 거는 예를 들어서 observation으로 입원시켜서 퇴원합니다. 그러니까 많은 이런 클리니컬 디시전 룰이 나왔죠. 오늘은 간단하게 pulmonary embolism에 대해서 잠깐 설명해 드리겠습니다. 거기에 대한 클리니컬 디시전 룰이 어떤 걸 사용하는지. We use Wells criteria for pulmonary embolism. Wells, W-E-L-L-S criteria. 그 criteria를 보면 you either have a clinical signs and symptom of DVT. You get a point of 3. PE, pulmonary embolism, is number 1 diagnosis or equally likely. You get a 0.3. Heart rate greater than 100. If you're tachycardic, you get a 1.5 score. If you're immobilized at least 3 days or surgery within previous 4 weeks, 한 달 이전에 수술을 했을 경우, you get a 1.5 score. Previously objectively diagnosed PE or DVT, you get a 1.5. Hemoptysis, you get a point of 1 point. Malignancy with treatment within 6 months or palliative, you get a score of 1. 여기서 6 or higher, it is considered high risk. Score between 2 to 6 is considered moderate risk. If it's less than 2, it's called low risk. 그러니까 우리는 지금 이런 PE를 생각을 하고 diagnosis, working diagnosis를 한다고 I make my resident use Wells criteria. Very good validated clinical decision rule. 만약에 여기가 score less than 2 아니면 3나 low to moderate, then we move on to something called PERC rule. If it's low criteria, we use PERC rule. PERC rule is a pulmonary embolism rule criteria that was made by our emergency physician doctor named Jeff Klein. PERC rule. PERC rule는 좀 다르죠. Age greater than 50, you get a yes, you get a score. Heart rate, again, 여기서 PERC rule도 heart rate greater than 100, you get a score. Yes. You get O2 sat, less than 95%, you get a score. Yes. Prior history of venous thromboembolism, you get a yes. Trauma or surgery within 4 weeks, yes. Hemoptysis, yes or no. Exogenous estrogen, yes or no. If you are on estrogen, you get a score. Unilateral leg swelling. So you have 8 criteria here in PERC. So if you're Wells criteria negative, and you could PERC them out. PERC negative. Study basically Wells negative or low probability, low pretest probability, and you use PERC. If PERC negative, no more further testing. No more further testing. If the Wells criteria is low but is positive PERC, you use D-dimer. You use high sensitive D-dimer. If the Wells, W-E-L-L-S, Wells criteria is moderate, you use high sensitive D-dimer. If it's positive, if it's a moderate risk, and they use D-dimer is positive, you go to CT scan, CT angio. If the Wells criteria is high pretest probability, you go straight to CT angio. That is what we use in our emergency department, and that's a standard of care. You could actually write in the chart. Medical regular system입니다. Wells criteria negative, PERC negative dictates no further testing. If the well is low, test, but the PERC is positive, you use D-dimer. If D-dimer is positive, you use CT angio. Moderate pretest probability for wells, you use high sensitive D-dimer. If it's high pretest probability, you go straight to imaging. PE는 굉장히 지금 흠하고 굉장히 흔한 disease고 one of those 5 things that you worry about in chest pain that I teach my first year resident. Is it an ACS, acute coronary syndrome / MI? Is it an aortic dissection? Is it a PE? Is it a Boerhaave syndrome? Is it tension pneumothorax? 그 중에서 가장 misdiagnose를 많이 나가고 있는 이 pulmonary embolism의 간단하게 clinical decision rule을 얘기했습니다. 다음에는 we're going to talk about submassive PE. Submassive PE. Not the small subsegmental PE, not those massive PE that you know. There's hypotensive, those are easy. But how do you work up the submassive PE that looks well? Or submassive PE with severe RV dysfunction, positive troponin, BNP, or syncope? How do you work them up? Well, how do you give a treatment? We're going to talk about PEITHO trial. PEITHO trial. PEITHO. We're going to talk about that. We're going to talk about top coat trial. Top coat. That was done by Jeff Klein. But the most important, MOPPET trial. MOPPET. MOPPET trial. For submassive PE. Do you use TPA? We're going to talk about that. For PE in the second session. 두 번째 세션에 얘기하고 오늘은 지금 first session은 we just talked about basic thing to how we use clinical decision rule to work up the pulmonary embolism. Use Wells criteria. Use PERC, PERC criteria. If the Wells shows low pretest probability and PERC is negative, no blood test is needed. If it's low pretest probability for Wells but positive PERC, you use D-dimer. Again, moderate pretest probability, you go straight to D-dimer. If it's positive, do CT angio. For high pretest probability for Wells criteria, you go straight to CT angio. 옛날처럼 그런 clinical gestalt는 모자르죠. You need to use clinical decision rule for this one. It's very highly validated and very sensitive. You'll miss few percent, but it's acceptable in the community right now. So use it wisely. 이용하시고 두 번째 pulmonary embolism section에 we're going to talk deeply about RV dysfunction, all the treatment options, heparin, TNK, TPA, and other catheter-based thrombolysis. We're going to use how we dissolve the clot. 여러 가지 종류에 대해서는 두 번째 세션에서 말씀드리겠습니다. 감사합니다. KoreanEMDocs.org의 크리스토퍼 레이 이종수였습니다. 감사합니다.